I'm Luann. I'm a PA at Little Falls Orthopedics. I've been a PA for 18 years. Prior to that, I was an operating room nurse, and I did that for 23 years. So went back to school and doing what I love to do. I work with Dr. Edgerton. He's one of the orthopedic surgeons at Little Falls. Some of you might be familiar with him. There are three other orthopedic surgeons in Little Falls now. Dr. Jorgensen, Dr. Johnson, Dr. Prosapio, Dr. Meyer retired, if people didn't know that. So anyway, welcome and thank you for coming. It's a large crowd. I think the biggest that we've ever had come to one of these talks, so certainly some interest in arthritis. So today we're going to talk about joint pain, hip and knees mostly, and the conservative versus the surgical treatment of pain in the knees or hips. Causes of arthritis pain. Birthdays. You know, unfortunately we have those birthdays, and just causes wear and tear in the knees over the years, and that brings you to see us. Genetically, you know, sometimes you're predisposed to arthritis just because your parents had it, or, you know, some people talk about, oh yeah, my dad had his knees replaced, and so we know those people are probably on the road to that as well. Wear and tear, just like I said, birthdays and everyday use, you know, and some people's jobs require a lot more wear and tear on knees than others. And trauma is another way that people can get arthritis. So if you've ever had an injury to your hip or your knee or your shoulder, you certainly can develop traumatic arthritis over time. And we treat it the same way, it's just that it gets there differently than just regular osteoarthritis. Other causes, sometimes back pain can cause people to have problems with arthritis. Their gait is such that they don't walk like they normally would, and so it kind of throws off their joints. But and people can have arthritis in the back too, you know. So symptoms of arthritis: pain, you know, and just plain old pain doesn't necessarily mean it's arthritis. You can have other things going on in your joints. You can have torn cartilage, or, you know, gout even, but pain is usually what people come in to see the doctor for. Giving out. So if you have symptoms of walking along and suddenly your knee kind of gives on you, that is another symptom of arthritis. Clicking and grinding. You know, we all click and grind. You can hear me coming up the stairs, you know, a mile away because my kneecaps grind, but the clicking and grinding is okay as long as it's not painful. And what that typically represents is the beginning of the wearing away of the surface cartilage on the bones. So, swelling, you know, you got fluid on the knee's just plain swollen. It sometimes can get red and hot. And it can be caused by arthritis, or it could be caused by other things. Warmth around the joint. So arthritis, anything that ends in itis is an inflammation problem. So you got inflammation of the bone, and it causes the knee to swell and become warm and sometimes red. Weakness. So the weakness isn't typically caused by the arthritis, it's a result of the arthritis. So because we hurt, we don't get out and move around as much as we should, And so our muscles tend to get weak in our legs and our hips, and so weakness can be another symptom. Types of arthritis. So the most common type is osteoarthritis. Probably the secondary most common arthritis is rheumatoid. And rheumatoid is an autoimmune disorder of the joints. So if you see people where their hands and their fingers deviate to one side, especially at these knuckles, those people, you can typically figure that they're rheumatoid. If you've got the knobby bones like I see in some of people's hands, I'm getting them too, that is osteoarthritis. We talked about post-traumatic arthritis, somebody that had an injury early in life and now is developing arthritis probably sooner than they would have otherwise, is caused by the trauma. And then there's hundreds of other arthritis. Psoriatic, you've probably seen the commercials on TV where the golfers got psoriatic arthritis. You know, that's one type. Seronegative, and there's a bunch more, but like I said, the most common is osteo. So arthritis conservative treatments. Start out with activity modification. This just doesn't mean just quit walking or quit doing anything. You know, just back off on the things that you're doing that make your joints hurt. Another thing that we try to use, and it can be difficult sometimes because of the aging population and not wanting to be on anti-inflammatories, but NSAIDs, ibuprofen, Aleve, there's a couple other ones out there, and they're anti-inflammatory, so they take care of the arthritis, help take the inflammation down. Another good pain reliever that I like is just plain old Tylenol. You know, I don't think Tylenol gets a fair shake. It's a good analgesic or a pain reliever that's not narcotic, and it doesn't, you know, damage the kidneys like the anti-inflammatories do. And you can mix the two. You know, if you're taking an NSAID or an anti-inflammatory, but it just doesn't quite get you through to the next 8 hours, you can take some Tylenol on top of it. There are two different types of drugs. So medications, narcotic analgesics. Now, we stay away from those, and in fact, the government is putting the screws down that we are not allowed to give narcotics to patients just for their arthritis pain. We use them for fractures and for surgery, post-surgery pain control. And they're even cracking down on this further that we can only give you 30 days of narcotics after surgery. So we have other means to help control surgical pain, and talk about that later. Glucosamine. So you've heard of joint bioflex or whatever. It's glucosamine with a chondroitin. Sometimes it has a compound in it called MSM. I would say if I took 100 people and had them take this, about 50% of them would get relief of their arthritis pain with the glucosamine. The one thing you need to remember is you need to take it at least 60 days before you say, yeah, it helped, or nah, it didn't do a thing for me. And then after 60 days, if you keep taking it and you don't feel like it's working, it's only hurting your pocketbook. Injections. So we have a couple different types of injections we can use. The first one and the first line that we use is steroids, cortisone, prednisone, whatever you want to call it. Steroids are anti-inflammatories. They are the strongest anti-inflammatories there is. And when you get an injection of a steroid, it's putting it right where it needs to be in the joint, where it's going to do the most good. It doesn't spread through your whole body. Now you can take it by pill form, But that goes to your whole body and would not target the joint that's given you the most trouble. Viscosupplementation, so that is, if you've ever heard of it or if anybody's ever had it, it is the rooster comb shot. It is chicken grease, you know, whatever you want to call it, but, and that's an option, especially if you've had the cortisone injections and they quit working for you. The next step would be to try a viscosupplementation. Now it's made out of a hyaluronic acid. If you've watched enough television and seen commercials for women's facial creams, they'll tell you that it's got hyaluronic acid in it. So what the hyaluronic acid does is it plumps up the skin and reduces the amount of wrinkles. So what it'll do in your knee, it'll take the remaining cartilage in your knee and plump it up and help create a cushion in the knee joint. And it's also an anti-inflammatory, not so much as the cortisone though. We have two different types we keep at the office. One is Synvisc and the other is Euflexa. So the Synvisc is actually made out of the chicken comb. So anybody who's allergic to chicken or eggs, we can't give them that. The other one is manufactured in a lab. They're both hyaluronic acid and they both work equally as well. Again, if I gave 100 people this shot, 50% of them will get relief and 50% won't. We don't know which ones they are. It's just a crapshoot, if you will, but it's always worth a shot. The next treatment for conservative treatment of arthritis is knee arthroscopy. And that's where you go in with a tiny little scope, you go in and clean up all the torn and worn tissue as good as you can, kind of flush out those bad proteins that are made in the knee because of arthritis, and it'll give people a short-term time of relief of their pain. It's not going to last forever because typically when we go in there we see bare bone, you know, with a little bit of cartilage left. But it'll buy some time. And then finally is the joint replacement. That is the final step. And we don't push people into joint replacement. I think the way to look at it is we see you, we see your x-rays, we see your symptoms, and we know that you need one, but we want you to be the people that come to us and say, you know what, I just can't do what I'd like to do. I can't live my life like I used to. I'm ready to have this done. Because it's a big step. You know, we don't want people just to go into it lightly and not think that it's, and it doesn't replace your natural knee. It just takes away the arthritic bone and takes away your pain, hopefully. Okay? So there's 3 compartments in a knee. Yeah, we're looking at this one, and the number 1 compartment we call the patellofemoral compartment. So it's behind the kneecap, but against the femur. So women have more common patellofemoral type arthritis, and that is because when we go through puberty, our feet stay here, but our hips go like this. And so it pulls your kneecap kind of off to the side, and people have problems developing patellofemoral syndrome because of that. The next 2 compartments are what we call the medial and the lateral compartment. So the medial compartment is number 2. That's on the inside part of the knee, right here. And then the lateral compartment is number 3. That is on the outside. Okay? Effects of arthritis. Well, we equate it to wearing of the rubber on your tires. You know, there's different degrees of wearing away of the cartilage and development of arthritis. It gets primarily is in the this area of the knee and then behind the kneecap, certainly. What you tend to see initially is that joint space between the femur and the tibia tends to narrow down. That tells me that the cartilage is either torn or worn or you're working on bone arthritis. So the treads aren't, they're wearing a little bit, but they're not bad. The next development is the wearing away of the treads. And you can see on the tire here, that one looks like it needed an alignment, but the treads out here are fine, but these here are starting to wear away. And so as you lose joint space, your bone collapses on one another and you develop arthritis. And this one not quite so bad, but it's on the way. And then there's the third stage of arthritis, and that's where you're riding on the rims. There's no tire, there's no rubber left, and this is pretty significant joint arthritis. I'm not saying people can't live with this. I've seen people that have done it, but we'll try all the conservative treatment we can until it's your time to pull the trigger, if you will, and get the joint replacement done. You can't regrow cartilage. That's, a lot of people think you can regrow it. It just, once it's gone, it is gone. So good knee versus bad knee. Normal knee is the one on the left-hand side there. And then in the second picture, there's joint space narrowing. On that particular one, the joint space narrowing is on the outside of the knee. And that's the inside of the knee. And the inside of the knee, or the medial compartment, is typically the first compartment to collapse. Sometimes people do develop lateral compartment arthritis, but it's not as common. Now we'll talk about the hip joint. So the hip is made up of the femur bone with the ball part, and then the pelvis creates the acetabulum, or the socket. There is a joint capsule around the hip joint, and it's protected by this rubber gasket here called the labrum. And this goes all the way around and keeps it in where it should be, and also protects it from developing arthritis. Good versus bad hip. So on this first picture, we're looking at the joint space. You'll often hear us talk about your joint spaces. So there's good joint space in that first picture, and then the second one, you can see where the joint space is starting to collapse. There's also development of bone spurs, or what we call osteophytes. And that happens because the cartilage is worn and you're rubbing bone on bone, so your body knows nothing else to do but to make more bone. So it's rubbing together, making more bone, and it has no place to put the bone but outside the joint, or the weight-bearing surface, and that's what creates those bone spurs. Surgical options for the knee. Again, we talked about arthroscopy, minimally invasive. You're in and out of the hospital the same day. And you just go in and trim some of the cartilage away that's torn and worn, clean up anything and smooth it out as best as you can. And it's a temporary fix, It'll give people a few more months before they say, it's just not doing very well, not doing good, and I think it's time for a replacement. But just put these two little instruments in there. They're about 4.5 millimeters each, and you go home the next day, and within a week or two, you're back to doing what you used to do. Now, knee arthroscopy isn't for everybody, If we look at your x-rays and you have absolutely no joint space within your joint, it's probably going to be a waste of time. We might be better off doing shots or, anything like that to get you down the road a little farther. So in a knee arthroscopy, what we're looking at, this is the femur and this would be the tibia. In between there is meniscus, and that's a normal looking meniscus. Here's looking at the outside part of the knee, again your femur, tibia, And the meniscus, those are good-looking meniscus. Here is just demonstrating, so this is the back side of the kneecap. Got a little metal probe in there and just kind of poking up against the bone, if you will, and it starts to soften. That's the first sign of the development of arthritis. The bone gets soft. And then this is just an anterior cruciate ligament. Partial knee replacements. There are a couple doctors that do those, and they're the right choice for the right people. You have to have only one compartment of arthritis. So that medial space is the one compartment. The kneecap and the lateral side are fine, plus your anterior cruciate ligament needs to be intact. So not everybody qualifies for that type of thing, but if you do, we have Dr. Prosapio does those. And this is a full knee replacement, and I have some models up here that you guys can wander up lately and take a look at them. Typically what we do, it's basic carpentry, if you will. We have saws, we have drills, hammers, and all that stuff, but they're sterile and they're high quality, high grade equipment. But we cut away the bone on the femur with some jigs that you use to make several cuts. And then we don't do that on the tibia, we just make a nice straight cut, removing all the arthritis. And then between there, at the end of the surgery, you snap a little plastic liner. So instead of being bone on bone, you are now metal against plastic. And you'll hear that clunk. You know, you'll hear it more than anybody else will, but because bone conduction, you're going to hear that clunking in your knee, and that's normal. I don't know if any of you have joint replacements in here. Do you ever feel that clunk? Hip arthroscopy. So typically for arthritic patients, hip arthroscopy is not as big of a operation option. But for younger people that have torn labrum, or they have some sort of what we call cam impingement, so when they get their hip into a certain position and it catches, they can go in and kind of smooth off that bone so they don't have that catch in there. But for older people, it's probably not one of the big things that we do. And the replacement options, again, there's a model up here that you can look at. But what we do for hip replacement is we take the old ball off, the arthritic ball, and replace it with a metal ball. We put a metal stem down into the femur, and all this stuff is pressed into place with tolerances of less than 1 millimeter. So, and they also have some ingrown product on the outside to help your body incorporate that metal stem into the femur. On the socket side, we just take a little, it looks like a cheese grater, like a half moon cheese grater, and it just goes in and it reams out all that arthritic bone in there. And then again, we press fit it into place, and it's got some ingrowth on it. And once in a while, you'll see where they put a screw up into the acetabulum, and that's just more of a belt and suspenders, if you will, to keep it from rotating. Otherwise, it should be fitting in there pretty tight. So now again, instead of bone on bone, you're metal against plastic. So between this ball right here, which is usually cobalt chrome or even porcelain or ceramic, there is a metal liner in between there. It used to say joint replacement lasts for 10 or 15 years, and now we're looking at more like 20 or 25 because of the advances in medicine with the components. So here's a little anatomy of a hip. That first picture shows an arthritic hip. The second one looks more like a normal hip. And a couple different ways to replace the hip. One is to put the metal stem down the femur and the metal cup in here. This procedure, which was called resurfacing a while back, you would just resurface the ball and put it into the regular cup, the regular acetabulum, if you will. Those have also fallen out of favor for various reasons. You have to be the perfect candidate, if you will, to have any of that kind of stuff done. Approaches to the knee. So over the years, the approach to a total knee replacement hasn't really changed as much. Now with the hip, we have been doing what we call an anterior hip replacement. So it used to be you would have your incision way back here, and they would dislocate your leg this way and put your components in. Now we're finding with this anterior approach, and your incision is right about here. You don't have to take down as much muscle as you do with the posterior approach. People recover quicker from it and do quite well. The surgery is done with the use of radiology. So we are watching the components go in by using an X-ray machine. So I think the anterior approach also is better because you get the cup and the stem in there in the exact spot that you want to avoid it from dislocating. I'm not sure, sir, what you had done, if yours was from the back or from the front.
The back.
And it probably a few years ago. Yeah.
20.
Yeah. See, and we weren't doing those 20 years ago. I think about 2005 is when I started helping with those. So here's your traditional incision. It goes along the buttock, and it's kind of in the back there. Your anterior incision is right below the crease. Hip approaches, pros and cons. The muscle sparing, like I said, the anterior approach, or putting it in from the front, you spare the muscle. You don't take the muscle down like you would do from a posterior approach. And that's the only way to get at the hip socket, is to take down the muscle when done from the backside. Hip precautions, I touched on those a little bit. So avoiding getting in extremes of position. So the one thing I tell people that have the anterior approach is, what side of bed do you get out on? If you're getting out of bed on this side and you had your left hip done, we don't want you stepping out like that. So they'll teach you with therapy that you swing both legs together. And with the traditional approach, they want you to avoid more of the flexion at the hip, because it can pop out the back. Once in a while it'll pop out the front, but and it's kind of a big deal, you know. You dislocate once, we put you back in, put you in braces, and hopefully it scars down. But you dislocate 2 or 3 times, you're probably going to get a revision of some sort, either by making the leg a little bit longer, or by changing the position of that cup. And any surgeon will tell you the product of a hip replacement is not to make your legs equal length. Sometimes you have to make them uneven in order for it to be a stable hip, so that it does not dislocate easily. So you may be a little longer, a little shorter, depending on the approach and and whether or not you have arthritis on the other side. You know, if we do one side but you need the other side done too, we don't worry so much about this one. We just want it in a stable place where it's not going to dislocate. And then we try to match the other side. Not always able to do it. You know, it's like sometimes comparing apples and oranges. Recovery time. So the recovery time is typically about 6 weeks. The anterior people kind of get out of the gate a little quicker. So within 2 weeks, they're ready to go. They come into our office walking with their cane twirling in their hand, like Charlie Chaplin. But at 6 weeks, they are equal with the people that didn't have the anterior. And the downside to being recovered quicker is that you do too much. So then you say, oh, I feel pretty good today. You go outside and walk a bit or do something else. And the next day you're like, ugh, probably shouldn't have done that. All right. And then the long-term outcomes, like I said, are equal. Knee recovery. Hospital stay is dependent on the patient's health and the home situation. So if you have no medical issues, you have somebody at home that can take care of you when you are discharged from the hospital, you'll typically go home the next day. If you have medical issues, if you have no one to take care of you, you may qualify for a swing bed for a short while or be placed into a care center until you're ready to go home. There's also the option of home health, where they can come into your house and do your exercises for you, but you still would need to have somebody there with you. Therapy begins the same day. With the new techniques we have for pain control after surgery, and I don't know if anybody's had a replacement recently, but they put a pain pump catheter into the muscle. So you are standing up by the side of your bed the night of surgery and doing small things. And then we also use a CPM machine, if anybody's had that in the hospital. It's just a little gadget that your leg sits in it and it automatically bends and straightens. You start out with small amounts and then gradually add a few more degrees every day or every week. Some people do get those for home use. I know Dr. Edgerton likes to have them for his patients. Weight bearing to tolerance. You can put as much weight on that as you're able to. We recommend a walker for the first couple weeks, especially just getting used to that new knee. And if you're going to go outside, it'd be prudent to use a walker, especially if you're going to go on uneven ground. A fall on a newly implanted joint replacement is a big deal. You can fracture around it, you can dislocate it, and people rather be safe and use a walker. And then as you feel comfortable, graduate to a cane and that type of thing. Oh, here we go. Graduate to a cane in 2 to 4 weeks. We wean you off the cane in 4 to 6 weeks, but some people like it for just, security blanket, just to have it there in case they need it. 80% of the people are good to go at 12 weeks. So you can plan for about 3 months. Every once in a while, there's somebody out there that takes 9 months to a year to say, you know what, I feel good again, So it's not a short-term process. It takes a little bit. And you continue to build up your strength and your stamina as time goes on. And like I said before, our muscles get weak before surgery because of lack of use, and so those muscles have now got to be built up again and made strong. Hip recovery is a little longer stay, 2 to 3 days in the hospital. We won't kick you out the next day doing that. Therapy again begins immediately. We have you standing up that night if it's not too late in the day. Weight bearing is tolerated again with a walker. And then the hip precautions we talked about, preventing the dislocating of the hip. Graduate to a cane again in 2 to 4 weeks and wean off the cane in 4 to 6 weeks. With the knees, 80% of them are recovered within 12 weeks. And then again, continue to build up strength and stamina. So for follow-ups, I see Dr. Edgerton's patients 2 weeks after surgery, pretty much just check their wound and make sure things are going okay. And then he would see you 6 weeks after surgery, 3 months, 9 months, a year, you know, and sooner if you're having some issues. And then once you get to the 1 year mark, you can just follow up with them every year or every other year. The next topic is dental antibiotics, and there's been a lot of controversy from the dental community about that. We recommend people get antibiotics before they have dental cleanings or any oral work like root canals or things like that. Mostly because the antibiotics are a small price to pay for what could be a potentially big problem, implant infection. If you do get an infection, we take all the implants out, put a spacer in there that has antibiotics. You get IV antibiotics for 8 to 12 weeks. We're checking some labs. We're looking for inflammatory markers, and then eventually put the implants back in, different ones, not the infected ones. So anyway, the dentists are telling us, well, there's not a germ in your mouth that's going to infect a joint. That's probably true, but for a small price of a few pills before your dental cleaning to prevent an infection, we feel is important. Now that may change down the road. You know, there's a lot of talk out there about discontinuing those antibiotics, but I don't think at Little Falls Ortho we're ready to do that yet. But you do also, including your teeth, if you have a sinus infection, a lung infection, a bladder infection, a sore that is draining pus and won't heal, you need to see your primary care physician and get put on something for that. Metal implants like bugs, and those bugs get into your bloodstream and they glom onto those parts before you know it. Continuing your home therapy, there's never a good reason to stop exercising, you know. Keeping your body strong and your knee strong and hip strong. And then just follow up as you need to. Some people need to be seen more often, and some people not quite so much. So it's all dependent and individual. Frequently asked questions. How long will it take for my pain to go away? Well, everybody's different. And I've seen people that come in at 2 weeks after surgery and they're only taking Tylenol. I've had people that for 4 to 6 weeks are still asking for their narcotics. Well, the government's going to kibosh that so you can get them for 30 days, but I just think with the pain pump that they put in to control things afterwards, gets people on their feet earlier with less pain, and they don't need to use all these narcotics. But everybody's threshold for pain is different too, so we can't fault people who need a few more. How long do they last? Well, I think I touched on that. Used to be 10 to 15 years. We're looking more at 20 to 25 years. And even at 25 years, there's people out there that haven't worn out their joints. Does glucosamine and viscosupplementation work? And what's the best brand? Well, the one that doesn't empty your pocketbook. You know, buy the cheap stuff. The glucosamine is not regulated by the FDA. So they could have, it says 1,000 milligrams in there, but if somebody were to take it apart and dissect it, it may not be 1,000 milligrams at all. So one brand versus the other, they all say 1,000 milligrams. Just take the cheap one if you want to try it. And then as far as the visco, like I said, our office carries 2 products. One that's made out of chickens and one that isn't. They work equally well. Implants and recalls. So our office has not used a product that's been recalled by any of the companies. Our surgeons use products that are tried and true, that have been around for a while and have a good track record. There was a while back where people were getting these metal on metal hip implants, And their body started creating these metal ions within their bloodstream, and they'd get these chromium and cobalt ions and had to have those taken out because of that. We don't use those. What's the best type of hip approach? I would say it would be the one that your doctor is the most comfortable doing. There's surgeons out there that don't do the anterior approach. That doesn't mean what they do is wrong. It's just that they're most comfortable doing it that way, and they've had the most success doing it that way. Any post-operative precautions? Well, we always have to watch for infection. Another thing we watch for is blood clots. We do put you on a blood thinner after surgery, and lately we've only been doing that for a short while, and then we put you on a full-strength aspirin once or twice a day to help prevent blood clots, and that's for 30 days after surgery. And there's also risks of the components loosening down the road, wearing out, that type of thing. But we don't see that very often. Oh, blood clot infection, pain, that their motion isn't where they'd like it to be. Therapies is hard work, you know. Like Dr. Edgerton will tell you, if anybody's ever seen him, therapist and terrorist sound the same for a reason. I guess that's it. I'll be up here if anybody has some questions they haven't had answered. I have some pamphlets and some implants to look at.
And there's a shoe file here to take.
All right. Well, thank you all for coming. Have a good day.